So it's my pleasure to introduce Lee Mitsumori, who is a diagnostic radiology at Preauthorization, and he is going to be speaking with you about the work they've been doing under the Diagnostic Imaging Workgroup. Lee, all yours.
Good evening, and thank you for allowing me this opportunity to describe what we've been doing with the Diagnostic Imaging Workgroup. So we were chartered in April of last year, and currently we have 9 members. And the objectives of our work group are to evaluate and implement best practices for appropriate diagnostic imaging to hopefully achieve 4 things: improve health outcomes, reduce unnecessary care and associated costs, facilitate care coordination, and improve physician and patient satisfaction. So for this evening, what I'd like to talk about are 3 things. How to define appropriate imaging utilization, how can we measure imaging utilization, and kind of present a summary of what our current strategy is for managing appropriate imaging utilization. So I think one important concept is that we're not able to manage what we can't measure. And one problem we became very readily aware of in our first few meetings was that it's very difficult to define and measure what is appropriate imaging utilization. And always in the back of our mind, we have to kind of be aware that overly aggressively reducing imaging utilization can have some significant negative impacts. So what we decided to do is to use society and organizational guidelines that define the use of define the appropriate use of imaging. And the 3 sources that we're currently using is the Choosing Wisely initiative, the American College of Radiology Appropriate Use Criteria, and the HMSA third-party appropriateness criteria from the National Imaging Associates. So what Choosing Wisely is it's an initiative from the American Board of Internal Medicine that polled national medical societies and asked them to provide a list of at least 5 recommendations to describe what they felt to be appropriate utilization of different tests. And this is an example of the list from the American Academy of Family Physicians. And what you can see is that their list is not strictly related to imaging, and there's a variable effectiveness and impact for each recommendation. And of the 429 Choosing Wisely recommendations, 87 can be applied to diagnostic imaging. So American College of Radiology, back in 1993, began putting together evidence-based guidelines to help guide physicians in selecting the best test for a given clinical condition. This is just an example of appropriateness criteria for headache, where you can see there's a clinical condition. There's a list of different possible exams that can be ordered, and there's an appropriateness score, where 1 to 3 is considered inappropriate, 4 to 6 may be appropriate, and 7 through 9 being considered appropriate. And it also provides a summary of literature for each of these clinical conditions. And what the National Imaging Associates appropriate criteria is, it's basically criteria developed in-house by the NIA, and this is just an example for a CT ordered for headache. So it's a CPT-based appropriateness guidelines, and you can just see here an example of the type of wording that the NIA might use when they're trying to decide if a particular order for a CT is appropriate. And now moving on to different types of metrics and how we may be able to measure imaging utilization. Could we have the first polling question? So in the past year, what diagnosis code was the most frequently used for ordering a CT or MRI? A, headache, B, dizziness and giddiness, C, abnormal lung field finding, D, renal calculus, and E, solitary pulmonary nodule. Yeah, great, thanks. So one advantage of an ACO is that we do have access to a tremendous amount of data, and hopefully this data will allow us to identify areas of opportunity that we can then improve quality and reduce costs. In the next several slides, I'll just provide some example of the different types of data that we're looking at for this work group, and what they'll be. It'll be outpatient CT and MR utilization by our HP primary care providers. So this is just a plot showing the number of CT and MR exams ordered per month over the year from May 2015 to April 2016. And you can see in December the effect that the HMSA preauthorization implementation had. And we can also look at this type of data by facility. This is an example of trying to identify what are the most frequent diagnostic codes that are being ordered for a CT or MRI. And you can see that headache by far is the most frequently ordered clinical indication. This is an example of data at the provider level, where each row represents an individual provider. And you can see where we can see for each provider the number of attributable lives, the number of CT and number of MRI exams that are ordered. And this is a plot of the providers and their imaging utilization. So on the horizontal row is each HP provider, and the vertical axis is the number of CT and MRI exams ordered, normalized by 1,000 attributable lives. So back as of April of 2016, there were 112 primary care providers that were responsible for about 87,000 attributable lives. And you can see there's a tremendous range of imaging utilization, where one provider had 0, and the highest provider had 541 exams per 1,000 lives. And what's interesting, when you look at the top 25% of these providers, they were responsible for 29% of the attributable lives, but were responsible for almost half of the exams that were ordered. So this would suggest there's tremendous opportunity for us to try to figure out why there's such a discrepancy in imaging utilization for different providers. For each provider, we can look at the most frequent diagnostic codes that are being ordered. And where this might be helpful is then we can actually match up the type of exams that the particular provider is ordering with appropriate use criteria to hopefully see where educational might be helpful. And with HHP's partnership with HMSA, we have access to data on the NIA denials. So we can find out which diagnostic codes have the highest denial rates, and we can actually see reasons for particular denials. So what we hope to do is go through the reasons for denial, and see if there's anything that potentially having more information up front would be helpful in terms of ordering the exam. And finally, I just want to cover some of our strategies that we're looking to implement to improve appropriate imaging utilization. First is providing provider feedback. So you can see with all of this data that's available to us, we can rank providers based on utilization and denial frequency. We can review their exam types and indications that are being ordered, and then we can match these with the appropriate use guidelines that we have available. And then with this information, we can provide practice-tailored information regarding relevant appropriate use guidelines for each practice or provider. And we also want to try to leverage Epic to create Epic tools to help physicians order exams and to sort of guide them in selecting the most appropriate tests. So one of these Epic tools is a best practice alert. HPH has partnered with Stanson's Health and is actually a beta site for the development of these Epic-based decision support tools that are based on best practice alerts. And what a best practice alert is, that at the time of ordering, the Epic-based tool will mine data from Epic, and then based on appropriate criteria, decide if the exam request is appropriate. If it is, the exam order goes through. If it is deemed it may not be appropriate, the ordering physician or MA is then flagged to add in additional information. So at this time, the ordering person could provide information that then makes the algorithm deem the order appropriate, in which case the order would go through. If it's still deemed inappropriate, the ordering person has the ability to ignore the order or ignore the alert or cancel the order. So advantages of best practice alerts are that these are physician-designed alerts that can be based on appropriate use criteria that we select. It's built into Epic, and it is triggered at the time of order entry. So hopefully that provides a time and efficient workflow. And we do have data available on outcomes. So this is just an example of the type of data that's available with the best practice alerts, where it can show us the number of alerts that were fired, the number of alerts that were followed, and the number of alerts that were ignored. And we're also looking at putting together an imaging utilization dashboard to provide this type of information for each individual provider. And hopefully all of this will provide some tangible member benefits in the near future. Just recently, our HHP leadership has submitted a proposal to HMSA, where HMSA would remove their third-party pre-authorization requirements for HHP membership, and HHP will implement these Epic-based decision support tools to guide appropriate imaging exam ordering, and HHP will also monitor provider imaging utilization to provide feedback to physicians on performance and educate them on appropriate utilization. So if the proposal is approved, then we have the potential to replace HMSA's third-party pre-authorization with an HHP physician-driven solution to manage imaging utilization. Could I have the second polling question? So for those of you who have already encountered a best practice alert, have you found these to be not helpful and time-consuming? Have not encountered a BPA yet? Those being helpful but time-consuming. Great, thanks. So in closing, thank you for giving me this opportunity to introduce our work group. I've covered some of the projects and tasks that we have been involved with over the past year. This year was quite a steep learning curve, and we were presented with several external challenges. But I think the main message to me was that as an ACO, we do have the tools to help our membership with exam ordering and improve appropriate imaging utilization. So we look forward to the upcoming year. Thank you.